Bye.
Hey everybody, welcome to Knock Knock Eye with me, your host, Dr. Glaucomflecken, your one-stop shop for all things eyeballs. Thank you for joining me today. We got some fun stuff on tap. Later in the episode, my eyeball topic today is going to be a new series that I will sprinkle in occasionally, which is like zebras, things that I have never seen before. Eyeball things that you'll learn about, but are usually pretty rare and may never come up in your career whatsoever. And so there's still a good amount of diseases that just are mysterious to me. Like where are these things? Sometimes they happen in areas of the country or of the world that we just don't see up in the Pacific Northwest. But anyway, so I have one of those things today that I've never seen in my career, and I hope to never see it. So, stay tuned for that. That'll be probably after the first break. We'll get to that. First, I thought I'd talk a little bit about this recent skit that I published about the HHS. It's one of my classic Jimothy sketches where I am Jimothy interacting with his boss. In this case, I didn't explicitly say it was RFK Jr., but it's just the leader of the HHS, which is RFK Jr. I didn't do the voice because I don't feel right doing that. I don't know. It's, I don't like, it would be a more accurate impersonation, but I'm not really impersonating these people. That's not where the humor it lies in my content. It's more the jokes I write and kind of getting at more of the substance of what these people say and think and do. So anyway, so you're not going to hear me try to imitate that. I probably wouldn't be very good at it anyway. But anyway, the point of this, what spurred this video was this revelation that's come out from, I guess, some news sources have reported this, that HHS is going to come out with some kind of report that links Tylenol use, Acetaminophen use prenatally to autism. So this, you as you can imagine, like I've gotten some angry messages and comments and things about this. Most people kind of agree, and basically, the point of the video is to explore RFK Jr.'s interpretation of science and like what it means to do science and what it seems like is happening, which is trying to find studies that support his already made conclusion, which is not typically how science works, right? You have a hypothesis, but like you don't try to do research to satisfy your mind that you've already made up. Like that's kind of backwards there, right? And we already have, there's just last year, 2024, a sibling controlled trial published out of Sweden of over 2 million children that did not find a link between acetaminophen use and autism. So it's frustrating to like hear about a lot of money being put into studies that are to look into things that are pretty settled as far as the science is concerned. Science doesn't deal in certainty, right? Nothing. You cannot really prove something in science. Maybe in like math, obviously math, they have proofs, or physics. But in like medicine, there's not a lot of things that are like you prove something to be true. You have a mounting amount of evidence. You have high quality trials and studies that make the likelihood of that thing to be true very, 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 very high, right? That's like science. That's biomedical science and research and all that stuff. So anyway, it's frustrating when we have a lot of really good studies on these different things, and then we're using all this money to do more studies in what it seems like in search of an answer that like a particular group of people are really looking for, and not finding it. So I don't know. So it's just frustrating to me. I made the video and got some fun responses. And I've been thinking about that a lot because the keynote season is kicking up in the fall. I'm doing a lot of talks, and a question I get asked all the time is like, how do you deal with people that are mean to you on social media and angry. And one of my lesson to people is like you got to start to recognize positive feedback from like not positive versus negative feedback because you get both and that's okay. But I will say feedback that is worth your time. That's the distinguishing factor because there are some comments, there's some feedback you get that is reasonable. I have received negative feedback on videos from time to time. That is something I need to think about. And maybe I didn't say something that was accurate, or I didn't think about something from somebody else's perspective. And I need to address that. Like I've made mistakes with my content, and that's good feedback. All right. But there's a lot of feedback you get in the form of personal attacks and whatever it is that's really not worth your time as a content creator. It's just going to make you feel bad about yourself, and that's not productive. Right. And so part of doing this, posting, fighting misinformation, advocacy, whatever it is you're trying to do, a big part of that, especially as your platform grows, is just learning what to just ignore and what to take to heart. And so that's a hard thing. That's a hard thing to figure out. It takes time. I don't know, because it's hard to look at someone being mean to you and like not want to fight back against that. But man, nothing good comes out of like arguments on social media. I've never once seen a good thing come out of that other than putting on a show for all the other people. Like that's all and it's at the expense of your own mental health. So like it's like the classic joke is like don't get mad online. And there's a lot of truth to that. Like especially when it comes to like don't get mad at comments online. Like that's probably the more accurate thing. You can get mad. I get mad on social. I get mad in my content sometimes, but like getting mad at somebody else and like having a big back and forth fight, like who is that benefiting? Not the people having the argument, just the people that want to show. That's it. So anyway, uh, I like the video. I like I think I'm going to keep doing it. And it's not like I'm taking a political stance. It doesn't feel like I'm taking a political stance when I put content out there like about HHS and the things that these politicians do. Because first of all, I do it on the insurance side all the time. So why wouldn't I do it on the when talking about vaccines or any of the other policy decisions that are made using research and science? So anyway, but some people are not going to like it, and that's okay. That's all right. You can and you can take that feedback or leave it. All right. So another thing, let's see. Yeah, one more thing before we take a first break is I want to talk about GLP-1s a little bit. So um, I feel like there's more. It still feels like a miracle drug. Like first of all, I'm seeing ads everywhere for Wegovy, for oh my God, these companies, they are pushing these GLP-1s hard. I mean, for good reason. It seems like there's very few downsides, but one of the downsides I'm seeing as an ophthalmologist, I'm getting a lot more questions about from my patients, is this issue of like bleeding. People say, make sure you get bleeding in your eyes or you get swollen optic nerves. Well, I can address those two things in particular. So there was a study, I talked about it on this podcast not too long ago, that looked at they're like ophthalmologists were seeing an increased incidence of ischemic optic neuropathy. Now, this is a disease that occurs more frequently in people that have diabetes. So you're going to select just by virtue of the people that are typically on these GLP-1 medications, they're more likely to have diabetes or hypertension or other problems with their vasculature. And so they're going to already be at higher risk. So the question is does GLP-1, is it associated with an even higher risk? Does it increase that risk even more? And there was one study that I think it was in JAMA that said maybe, yeah, it looks like it. But then there have been subsequent studies that cast doubt on that. So it's still unsettled. I don't want you to think that this is settled science. It's not. We don't know for sure. It's really hard to tease apart the effect that this GLP-1 is having, um, you know, with regard to just the baseline risk that these patients have by virtue of their comorbid diseases, diabetes, hypertension. It would take a prospective controlled trial to try to tease this out. And we just don't have that, right? So I don't think anybody could say that, you know, I would never say as an ophthalmologist, no, I don't think you should be on this medication because it increases your risk of an ischemic optic neuropathy. Because you have to also have to factor in, even if there was like a slightly increased risk of that, well, look at the improved, like the improvement it's making in your like risk of coronary artery disease, right? Like that you got to balance these risks and benefits, right? Slightly increased risk of an ischemic optic neuropathy, way decreased risk of coronary artery disease. That's a trade-off you might be okay with, all right, if there did turn out to be the case with regard to the eyes. So you have to also factor in that, right? These God, it's just such a wide-reaching effect. We're seeing that potentially these medications decrease the risk of cancer, certain types of cancer, maybe even protect against dementia. I don't know. It's like I don't believe in miracle drugs. I think when we throw out miracle drug, that gets dicey because there have been some claims of that in the past, and it's never turned out to be what people think, and there's always a downside. So we got to be careful with that. But so it's like it almost just makes me a little bit uneasy that was just like so many good things coming out about these medications. Like when is the boot gonna, what is the term, boot gonna drop, foot gonna no, foot drop. That's a diagnosis. I don't know. You know what I'm saying? When are we gonna come back down to earth and realize that this wasn't as good as we were led to believe? But maybe that's just maybe I'm being overly skeptical. I don't know. But anyway, and the other thing is the bleeding. So this is a more recent thing, and in particular that people there are some grumblings on social media. I've seen it of it's like the GLP-1s increase your diabetic retinopathy. Well, keep in mind that just dramatically improving blood sugar control in people with diabetes, that alone like can actually temporarily increase the amount of diabetic retinopathy we see on exam. So you take someone who's just like a newly diabetic, you get them on insulin and their A1C just drops through the floor. First of all, that's actually not a good thing. Like, and any endocrinologist will tell you that. Like, you want to try to just a steady decline. You don't want to just really drop it too quickly because that can cause problems. They can go too low. But you also have problems like in ophthalmology, we will see with dramatic swings in blood sugar, high or low. Actually, you can get a temporary just flourishing of diabetic retinopathy, a bunch of bleeding, cotton wool spots, all this stuff. And eventually it will get better as you maintain a steady control of your blood sugar. But that might be just what we're seeing here. It's not so much the GLP medication itself is increasing diabetic retinopathy, but more these medications are helping people to dramatically improve their blood sugar control, and their A1Cs are dropping like a rock, and that's causing a temporary worsening of their diabetic retinopathy. Again, not a reason why I would tell someone don't be on a GLP-1, because you have to balance that with their improved cardiovascular health, which is a big deal, right? So, just I don't know what the point is. Maybe just to be careful when you see, like, especially on social media and like for like popular news outlets. I'm not picking anyone in particular, just like NBC, CBS, these random who just have these like clickbaity headlines, like, GLP-1 Wegovy leads to increased risk of blindness, like stuff like that. You got to take that with a grain of salt and really dig into what exactly they're talking about. All right. And so just be careful about that stuff. All right, let's take a break. Hey, Kristen.
Yeah.
Our kid came into our room last night and stole my blanket.
I feel bad for you, but I have to say I'm not surprised.
Oh, because it's my bubble cuddle blanket from Cozy Earth?
That is everyone's favorite blanket in this house.
But it's my blanket. You should get your own.
That's arguable.
Okay, we are getting everyone their own.
That would be the simplest solution to
because
this.
everybody wants
We all
a
want
Cozy
one.
Earth blanket.
We need one in every room.
And maybe even a couple extras just in case a guest takes it from us when they come over. And plus Cozy Earth offers a risk-free purchase. You know this?
I know, it's great. There's nothing to lose.
100-night sleep trial and a 10-year warranty. So head to CozyEarth.com and use code KNOCK for 40% off. And if you get a post-purchase survey, make sure you let them know that you heard about Cozy Earth right here on this podcast, because your bed should be more than just a place to sleep. It should be your happy place. Cozy Earth makes that possible. All right, so we're going to do an eyeball topic. This is Knock Knock Eye, after all. We've already talked a little bit about eyeballs. And then at the end, we will, I'll do some comments, a little Q&A. All right, so eyeballs. Okay, yeah, here's what we're going to do. So as I mentioned in the open, there's a handful of diseases that I have yet to see. I don't even really want to see them because they sound scary. They sound very scary. So the one that we're going to talk about today is called sympathetic ophthalmia. Sympathetic ophthalmia. That's OPHTHALMIA. Ophthalmia. Because all these words in ophthalmology, they got to be as hard as possible to say. All right. So here are the symptoms that you'll see with someone who has sympathetic ophthalmia. Bilateral eye pain, light sensitivity, poor vision, redness to the eyes, pain. Did I say pain? I already said pain. That doesn't sound fun, does it? So this you'll also see in patients who have a history of one of two things. Penetrating trauma. So they got poked in the eye, and I say poke in the eye, I mean like literally their eye, they had something that went into their eye, into the eyeball. Or a history of intraocular trauma, which is just a controlled poking of the eye. Most commonly, this disease will occur in patients who have had vitreoretinal surgery. So you had a retinal detachment, you had what's called a pars plana vitrectomy, where you go into the back of the eye and you suck out all the vitreous, all that jelly back there, so that you can reattach the retina, put some laser in. There's all kinds of reasons you would have a vitrectomy, but retinal detachment is one of them. But that kind of surgery, that's what we're talking about. And what happens, big picture for sympathetic ophthalmia, is that the other eye, this is why it's dangerous, because often when you have penetrating trauma or some kind of terrible disease or something that causes you to have retina surgery, it's sometimes you have poor vision in that eye as a result, especially with trauma. It's, the eye, not a great place to have trauma. So you can have just poor vision at baseline after recovering from a big trauma. Well, what happens with sympathetic ophthalmia is this is a disease that will affect the fellow eye. What happens is some of the tissue, there are certain tissues in the eye that are immune, what's the word? Immunoprotected. We'll just say immune protected, which means that you don't have a lot of blood flow in there. And so your immune system doesn't really encounter that tissue inside the eye. Well, what happens is when you have either a surgery or a traumatic injury, all of a sudden you might have more of your immune system, your blood flow, those immune cells, they get exposed to that tissue. And the tissue I'm talking about is mostly like your pigmented tissue. So what we call your uvea, which encompasses, it's a very vascular tissue that encompasses parts of the iris and the retina, what we call the choroid, the ciliary body. And what'll happen is when you have a big trauma, your immune system will encounter some of this tissue for the first time and will recognize it as foreign. Will recognize it as something that it needs to attack. And the result of that is that it will also recognize your fellow eye and attack that eye. And you get this dramatic inflammatory response. So you suspect this anytime there's inflammation that you see in the unaffected eye after a unilateral trauma or surgery. Now, this typically occurs like 4 to 8 weeks, but the scary part about this is that it can occur decades after the initial trauma. 30 years later, after you have a bad trauma to one eye, a penetrating trauma, you can get this in the fellow eye. But 90% of the time, roughly 90% of the time, it will occur within a year. All right. And just to give you some framework of how, because I can feel the anxiety building for some of you, because retina surgery is pretty common. Also, not unusual to have something poke you in the eye. People are like, oh shit, do I need to be concerned? Well, let me just put this into perspective. All right. The annual incidence, based on the literature we put it around 3 cases out of every 10 million. 10 million people. So 3 out of 10 million. This is not common. It's why I have never seen it. I have never seen this disease. All right. You go to like a big academic center where all the worst things come to that place, you're more likely to see it because that's where people go with rare things. But your average ophthalmologist is not going to see this. All right. It's very, very rare. So please do not worry about this. All right. Do not worry about this, but it's just it's something that is out there. It happens. All right. So what do we see on exam? So I mentioned inflammation. So what we'll see is severe inflammation in the front of the eye, what we call mutton fat, KP, keratic precipitates. We see these little white spots that develop on the inside of the cornea because there's so many white blood cells floating around in the eye that it accumulates into these spots. And then we also see some inflammatory spots in the back of the eye, what we call Dahlen-Fuchs nodules, because probably Dahlen and or Fuchs diagnosed it for the first time. I would love to have a Glaucomflecken something. Could someone let me name their thing that they find in the human body? I just want like a Glaucomflecken nodule, a Glaucomflecken bump. It doesn't have to. I don't need much. All right, just a Glaucomflecken, the Dr. G vein. Is there a vein that hasn't been named yet? I'll take a vein. I'll take a lymph node. Can I get a lymph node? Actually, I don't want a lymph node. I don't like lymph nodes. I don't like lymph. Not a big fan. I'll take a vein though. Vein sounds reasonable. I think I've earned it, folks. Okay. I'm just saying, like any anatomists have something for me? Let me know. And the reason this is such a deadly, or not deadly, very few things are deadly in ophthalmology. Ooh, that would be a good topic. What can kill you? What can kill you that your ophthalmologist will diagnose? Very short list. So the danger, the reason this is so bad is because this inflammation is massive. Because imagine your immune system all of a sudden tries to attack a large percentage of your eye or any part of your body. Like that's autoimmune disease can be very severe. And so the inflammation is severe. The loss of vision is severe. Patients can lose their eye from something like this. And so when you have that, also just getting to that diagnosis can be challenging. You got to have a good history. You got to ask, have you had any history of trauma? That's a question we always ask people when they come in for a first exam. Have you ever had any major eye trauma? Even if it was 30 years ago. I'll have patients that come see me for the first time in their 80s. And then when they were 8, a stick went into their eye because I can see a little scar on there. I was like, what happened there? So these are good things to get in the habit of asking your patients with just any kind of eye problem that comes in. Have you had any history of trauma to this eye? It doesn't matter how long ago it was. You can still get something like this. All right. So how do we treat this? So this is one of those rare things that we don't do this very often, but we will treat with high dose oral steroids. like 1 milligram per kilogram daily, to try to just decrease the amount of inflammation in the body as much as possible to try to control this. So that's where we'll start. We'll give topical eye drops as well. And if you're wondering what I keep looking at, if you're watching me on YouTube, it's because I have a review book I'm looking at just to remind myself. I learned these things at one point, but again, when you don't ever see something, these rare things, we got to look stuff up from time to time. My mind, although I do describe it as a steel trap, some stuff leaks out. It does, but I can always pull it back in. All right, so topical steroids as well. And sometimes we have these steroid pellets. This is kind of interesting. So for different diseases, you need to have a very localized, concentrated amount of steroid put into the eye, into the vitreous. So we have a couple different types of steroid pellets that you just take this big trocar thing, you just insert it right into the back of the eye, and then it'll slowly release steroid over the course of anywhere from 6 weeks to 3 months. Some of these things, and I think there may be even some that last like 6 months to a year. And so that's the level of steroid we're talking about. You might get oral steroids for sympathetic ophthalmia, as well as intravitreal steroids, as well as topical steroids. We're blasting that eye from all corners because this inflammation will eventually cause so much scarring in the eye, retinal detachments, inflammation and ischemia of the optic nerve, and the eye will eventually shrink down and become what we call ptysical. And then you have a blind, painful eye and you lose the eye. And so now for some patients, sometimes, and this is why there are some specialties in medicine that we have a lot of overlap. One of those is with rheumatology. I make fun of rheumatologists a lot. I don't know. They're smart. I take shots at people who are smarter than me. What can I say? They're incredibly brilliant people. And so when patients have a rare thing like this that requires frequent steroids, giant cell arteritis is another one. These patients have to be on steroids for months, sometimes years. If the dose is too high for a long period of time for systemic steroids, that comes with lots of problems. And so we will work together with a rheumatologist to work on some steroid sparing agents that might be useful in a patient who has sympathetic ophthalmia. But in general, long-term prognosis of this, it can't, if you catch it early and you treat it aggressively, it can be okay. You can have, the data I'm seeing here that says a long-term prognosis in patients treated with immunosuppressive therapy can be 80% of eyes that see 20/40, which is great. The challenge is getting to these patients as quickly as possible and being aggressive enough with your treatment. And the challenge is this: patients might need long-term, lifelong treatment of something like this. And so it's just a tough disease, a rare, fortunately, very, very, very rare. I can't stress that enough. All right, let's take one more break. Hey, Kristen.
Yeah.
I know that you love when I talk about the cute little mites.
Mm-hmm.
Yeah, but I thought we could take a break from that. Is that okay with you?
That's fine.
Yeah, because I'd like to focus on the eyelid symptoms and disease that an overgrowth of Demodex causes.
Okay, I like that idea. No mite talk.
So Demodex blepharitis, it often gets misdiagnosed or just missed entirely because a lot of symptoms overlap with other eye conditions.
Okay, so what are the top symptoms that people should look out for?
Usually itching along the eyelid margin, swelling, irritation, redness.
That sounds like it could be allergies or lots of other things too.
It could be a lot of things, but exactly. And the key is if your doctor spots crusties, on the margin of the eyelid.
Technical term.
Well, we call them collarettes, but, crusties is a good term. That tells you it's Demodex blepharitis right there.
Well, I really like that there's a clear sign to know for sure.
And once you're diagnosed, there's a prescription eye drop treatment available for this disease.
Ooh, that is good to know.
To learn about the common symptoms of Demodex blepharitis and more, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. All right, let's wrap up with some questions over at the YouTube channel at Glaucomfleckens. Go check that out. Leave a comment. That's where I get all of these comments that I respond to. So let's go through some of these. We have at Macaulay Clan North says there's no way to keep their enthusiasm when residency completely takes everything from you within your body. It literally drains you of everything that's left. That definitely sounds like someone who is in residency. That is the most depressing thing that I've heard, and is not wrong. Not wrong. Residency does take so much. It takes so much from you physically, mentally, emotionally. And the reason this comment was left is because I was talking about when I recently talked to a group of med students, and they were asking about how they keep their enthusiasm. And I noticed that when I speak to med students, pre-meds, med students, and people in residency, they seem more motivated. They have excitement about advocacy and changing healthcare and making things better and just seeing patients doing a good job. And then we lose that throughout our career because the healthcare system beats us down primarily. And this person's saying, well, it starts in residency. And I'd probably agree with you. I think it's hard and it beats us down. So, and the trick is trying to come out of it with something left in the tank to be able to contribute. And I'd say most people get there. Most people are there. I honestly do think it's just the 30-year career that you lose steam. Makes sense. That's a long time. Thank you for that comment. All right. So in this most recent episode, I did talk about like, what's the right time? Like, should we change the amount of time people are in med school? Should we change the years? Because people are always talking about that. Like, should we go down to 3 years? And I will say, looking at a lot of the comments, people have a lot of opinions on this. It's probably the comments skew more toward not making med school shorter, actually, which is a little bit surprising. But both sides feel differently, right? I have, so at Greener 8116, the 6-year program makes sense as the last 2 years of undergraduate school could easily become the first 2 years of med school. Residency is where real training comes in, and the first few years of private practice is where you learn even more from senior colleagues. I completely agree with this, and that's what I was saying is like maybe a 6-year program. But then I had another comment later on that says, well, maybe that's not the right case, because then you have undergrads that are expected to make this very important lifelong decision of going into med school earlier, maybe before they have enough experience to know exactly what they're getting into. That's also a good point, right? So what we're probably going to end up doing is nothing at all, folks. We're just going to keep it the same. So I don't know. At Bug Med said, just graduated from med school last May. I am now in a transitional year program. Shout out transitional year programs. That's what I did. One of the best years of my life. And plan on doing the match again this year. It's going back into the match. Why? Because I didn't rotate in the specialty that I fell in love with until late February of 4th year. Polar opposite field from what I did apply to. So that would be the danger, right, of shortening med school. You have less time to figure it out. You may end up somewhere where you don't want to be, and then you got to go backwards. I didn't choose ophthalmology until the very beginning of my 4th year, very late. So I see that point as well. So I don't know. Maybe the right answer is just we've settled on this 4 years of undergrad, 4 years of med school. Keep it the way it is. I think honestly, people would just be happier with lower tuition. Let's just do that. This in some way, keep it at 4 years, but let's lower the tuition so we don't have $300,000 in debt at the age of 32 or whenever it is you finish residency training. Here's a great question. I love this. At Sean P. Leslie, seeing as how the optic nerves make eyes practically part of the brain, not practically, the eyes are absolutely, they're just brain bubbles. That's all they are. Does being right-handed or left-handed have any impact on eyeballs? Like, am I right eye dominant, or is the left eye form and function the same as the right eye? So your eyes are identical, first of all. There's no difference between your right eye and your left eye. But it actually is important, and I will check dominance, handed dominance in people. And this is the situation I do that in. When I'm doing cataract surgery, some people can't afford the fancy multifocal lenses where I put a lens inside the eye that allows you in that eye and the other eye, each eye separately, to be able to see both distance and near. That takes a special lens. Insurance doesn't cover it. It's very expensive. But as an alternative, and I love this for people, we will sometimes do what's called monovision, where you have one eye that when I do cataract surgery, I set it for distance. The other eye, I set it for near. So you have this blended vision that gives you some glasses independence. Maybe not completely, but dramatically decreases your dependence on glasses. Not everybody can do that because it does decrease your depth perception a little bit, but it actually does work for a lot of people. Some people don't know which eye they should have be the distance eye. So I will check their eye dominance using a very fancy test where I have them look at a letter on the screen and I say, make a circle with your hand and hold it up in front of that letter with both eyes open. And I'm doing it right now to the camera. And you close one eye. I'm closing my left eye. I still see that letter. I still see the camera. I am right eye dominant just based on that. If I were to do it, I'll try to do it the other way. If I were to do this, there we go. And I close the right eye and I just see it with my left eye, then that's left eye dominant. I always put the distance lens in the dominant eye. People want to see good in the distance with their dominant eye, whether it's whatever it is you're doing in the distance. So anyway, that's where handedness comes into play. It's not so much handedness, but just right brain, left brain dominant. And so that's really the only overlap I can think of. But the eyes themselves are identical. They're mirror images of each other, right? So I guess they're not totally identical because they are like reversed or something. So anyway, but that's a great question. I think we'll leave it at that. Another person was very excited to find out that I'm a Texas Tech Red Raider. Go Raiders. They got a good football team this year. All right. That's it. Thank you so much for these comments, and leave some more. I love seeing what you guys have to say about these episodes. There was some of the only comments that I read on all of social media because we got like a little smaller, tight-knit community of people that like the podcast episodes, which is great for being able to actually see the feedback and see what you guys have to say. So give me some content ideas, some topic suggestions. You got a weird eyeball thing you want me to talk about, or just a random question that you or maybe your kid asked that you're like, I don't know, I never thought about that. That happens all the time in this household. Let me know. But thank you all for listening and watching. I'm your host, Dr. Glaucomflecken. Thanks to my executive producers, Aaron Cordy, Rob Goldman, and Shanti Brook. Editor and engineer, Jason Portizzo. Our music is by Omer Benzvi. We'll see you next time, everyone. Take care.
Knock, knock. Goodbye. Hey, Will.
Hey, what's up?
I've been thinking. The U.S. healthcare system, it needs some improvement.
Yeah, there's room for improvement.
Yeah,
sure.
It's a confusing, scary place for everybody involved.
Absolutely.
Physicians, families, patients, everybody.
Everybody. And I've experienced it from both sides, right? I'm a physician. I've also been a patient. So I wanted to use my platform to give people practical education, really the only way that I know how, by making jokes. So Dr. Glaucomflecken's really fun and super uplifting guide to American healthcare is out, and it's a free resource that includes all my videos from the 30 Days of Healthcare series, alongside deeper explanations, also reliable facts, emphasis on reliable.
Yes.
All right. Figures, numbers, insights into how each of us can fight for a more humane, better healthcare system. Also, it has jokes.
Did you mention the jokes?
I did. Jokes.
Okay.
Yes, definitely jokes.
Well, this guide is great for anyone looking to learn more about U.S. healthcare, but especially if you are experiencing it from the clinician side for the first time.
That's
We
right.
really hope you'll check it out.
Get the free guide sent straight to your inbox by signing up for our mailing list, glaucomflecken.com/healthcare. Enjoy. Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.